afternoon, everyone. It's a real pleasure to have the opportunity to be here. I am from the Provincial Health Services Authority, and I'm from British Columbia, but I'm originally from Ontario, and so it's been really a pleasure to be back in my hometown, and it's really quite beautiful here right now, so it's been good to be here. There's a lot of momentum right now around data and AI in healthcare, and there's a lot of expectation, and that really comes from the fact that our healthcare is failing us right now. And sort of our experience around this is that it's not that we have a shortage of ambition around AI, but rather it's on the execution side. And specifically, it's about how do we actually make AI work for patients, for providers? Like, how are we actually doing this to make it meaningful? And it's not easy. It's challenging. And so I just want to take today to take you a bit through our journey, and especially and specifically around cancer care, where we've been working with fragmented data and really trying to connect it in a usable way for the patient, around the patient, and ultimately to try and use that for better decision making. So let me just make this real for a moment. How many of you, either personally or a family member, have experienced something like this? You have gone to a specialist and they don't have your full medical history. You are visiting your GP and they didn't know that you are just recently in hospital. You're waiting for an MRI and you have no idea where you're on the waiting list, or how long you have to wait. Or you've had a biopsy and you're waiting for the results and you don't know who to call. And through all of this, you're sort of asking yourself, who's coordinating my care? And this isn't a failure of your individual providers, of your physicians, of your radiologists, of your surgeons. It's really it's what happens when our system is fragmented. Because from the system's perspective, these are all separate events. It's a test, it's a referral, it's a report, it's a consult. But from the patient, it's one continuous journey. And if the information isn't connected across that journey, we have no idea where are those delays occurring, where are people at risk that we are just sort of sitting on a wait list, and when can we intervene when it matters most. And so the shift that we've been really working on and have been really focused upon is from really looking at those fragmented systems to a connected patient journey. So we started with the BC Cancer Registry. It's a very strong asset. It's a population-based, high quality, and it's really critical for both planning and for reporting. But operationally, it was really under pressure. We had very, very high volumes of both pathology and imaging reports. Most of that was unstructured. And we had a very heavy reliance on manual review. So we had these tumor registers that had to really sift through this material and try and identify which were cancer cases. We had an 18-month lag time. So from the point in which the data was available to the point in which we had actually gone through those reports was 18 months. So that meant we could not make the data available fast enough to actually support care. And that was really the core problem that we were trying to solve. So we really made a deliberate decision about where to start. The work that we started with didn't start with patient-facing AI. In fact, we actually chose not to start there. At the time for us, AI was really relatively new. So rather than applying it in direct clinical care, we kind of looked at our back-end processes, not our back-ends. And we wanted to look at, like, how can we test AI safely? And where can we scale and learn and improve? And how can that actually help us from a clinical care perspective? And so with over 90% of reportable tumors confirmed by a pathology report, we focused on the pathology reports. And what we did was we developed an AI algorithm in order to classify our pathology reports, to reduce the manual effort, and to really move toward real-time data. And so once we made that decision to start in the back end, this is how the capability evolved. So we didn't go from manual to automated overnight. It actually was a very long progression. It took us at least a year and a half, 2 years. We started to begin with identifying reportable cases in real time. And so that replaced a large amount of manual review by our tumor registrars. Then we moved into automating how the cases were distributed and the work was distributed. So we had breast cancer tumor registrars. So we, sent all the breast cancer tumors to that registrar, prostate cancer, and colorectal cancer, so forth. And so by routing the cases to the right cancer groups, we reduced bottlenecks and automatically just improved our efficiency. And then we started extracting structured data from text, and we used NLP to really pull out some of the key variables from unstructured data. And critically, what we did was we built ongoing auditing and monitoring into the whole process. And that's where the shift actually really occurred for us, because we actually moved away from experimenting with AI at that time to really running it as part of our operation. And that's what really matters, because if you're not monitoring and validating and maintaining it, then you can't have AI production. And so what started as being sort of a pilot process in terms of how do we help our registrars in reducing some of the manual reviews actually ended up being the backbone for our registry. And this is just an example of how we actually transform the data itself. Most of the clinical, really rich information, especially in cancer, is buried in unstructured text. And this is an example of a pathology report. And we see pathology reports, imaging reports, they're all very, very rich in detail, but they are hard to use consistently. They vary by lab, they vary by hospital. Everybody has their own format, their own nomenclature, their own report. And so the question became, how do we take that text and make it usable? And this is where we applied NLP to extract some really key elements like the site, the cancer site, the histology, and the laterality. And that really allowed us to do two things. The first was to really automatically handle some straightforward cases. So breast and prostate are actually fairly easy cases for us to record and register and to really understand what's going on. And so we just peeled all of that workload aside from our registers and really handled that work automatically. Second, it allowed our registrars to actually focus on areas where it added value. So recurrent cases are very, very hard to find, to record, and to register. And so that was really the shift for us. It wasn't so much in us automating the work, but it was really improving where our expertise were being used. And then from a system perspective, it also made our data usable. So it was structured, it was consistent, and it was timely. At this point, we had the ability to structure our data and use it operationally. So the next question was, can we do better than some of the off-the-shelf models if we use our own data? And the answer consistently was yes. So we didn't just build one model, we actually built a suite of models, each of them designed for different purposes. Some were lighter and efficient for high volume work. So the BC Cancer Registry Tron Base was an example of that. Some were more powerful for really complex cases, complex cancer cases. Some were designed to read full pathology reports or imaging reports. And some were generative for more advanced tasks, like the BC Cancer Registry GEMMA. And so no one model does everything. We had to really design a capability of models. And the capability is not just a technology capability. We also had to build the expertise in our data scientists. Public sector has a very practical problem, and that's that we can't really afford data scientists. And so having that deep data science talent is really challenging for us to have on a consistent basis. And so we partnered with the UBC Data Science Institute, and we brought together a lot of their expertise. We brought our clinical expertise, and we brought our real-world data together. And we started to build a pipeline because we brought these fellows in early on in their training. We gave them data. We got them excited about the work. and some of them stayed. And so that allowed us to build a bit of a capability, not a large capability, but a bit of a capability, as well as to continue to have that pipeline of fellows in our practice. Really critical to all of this is that all of it is shaped by clinicians. So we don't do anything without our clinicians who are really tight in our feedback loop. So the models that we develop really reflect how care is delivered. And so what we found consistently was that models trained on BC's own data always outperformed generic models. And this is where it moved into real operations. What you're seeing here is that we moved from manual to assisted to automated workflows. And it wasn't just a technical shift, it really actually fundamentally changed how our registry staff operated. So instead of them manually reviewing every report, structured data was generated directly from text, straightforward cases were automatically handled, and our experts were focused in areas where they added most value. And this reduced our backlog, it made the data more usable, and it also improved the consistency and quality of our data. And so importantly around this, even though we started with a back-end process, we moved from it being a delayed reporting toward more real-time data availability. So some of the real rich data, like stage and histology and site that comes from the registry, is now available in almost real time to our clinicians. The other piece that came out of this was actually a real benefit was that we started to develop our own intellectual property. And that mattered for two reasons. First of all, we were able to scale this capability beyond BC. So we've actually implemented the proprietary methods for de-identification and classification in many provinces across Canada, and we're doing that, just kind of free of charge to try to, scale and to provide benefit to other Canadians. But we also have extended this work internationally. So we're selling it. We're selling it in the United States, we're selling it in Australia, and so we're generating not a lot of revenue, but something to get excited about at the very least. So this wasn't just about improving one program. It actually created a reusable, scalable capability with really value beyond the original use case. But there still was a limitation to this because, this was one use case. And so the next question is, how do we take this and make it usable across the system? And that's where our Panda comes in. We're healthcare, so we like cute, cuddly animals. PHSA's platform for analytics and data. And Panda is really our integrated data platform, and it helps to connect everything together. AI gave us structured, high-quality data, but Panda was what makes that data usable at scale. And it really brings together in near real time most of our data. So registry data, clinical systems, treatment data, operational data, and most importantly, it links them into a longitudinal view of the patient. So instead of now historically looking at isolated events, we can now understand the full patient journey from cradle to grave. And this is really the key shift for us, from isolated insights to system-level intelligence. And this is really what sits underneath the platform. This is the scale and capability that makes Panda work. We're talking about actually decades of data, hundreds of data sets, and billions of records. But actually, the scale is not the most important part. What matters is the linkage. It's consistent and it's reliable, and it's across systems, it's across settings, and it's over time. Because if you don't have the patient journey, then you, again, just have those disconnected data points. And so what Panda enables us is a persistent, longitudinal view of the patient, where data is linked, it's de-identified, it's refreshed regularly, and it's consistently structured. And that's what's really allowed us to move, looking at individual events, to understanding the full pathway. So this is where the work really starts to move beyond the registry and into clinical and system impact. At a high level, what this shift really enables is going from insight to action. And I want to take just a moment to give you two examples. The first is what we call the Can Try project, and it actually acts on individual patients and has a benefit to individual patients. And it's about identifying high-risk cases early and then making intervention happen early in care. The second is the Cancer Diagnostic Pathway Data Project, which improves the system. And both depend on the same foundation. What we're doing is taking unstructured data, we're turning it into structured signals, and then connecting it across the system. And so this is a shift from taking data and analytics in the back end and really influencing care delivery. And I think it's really important, especially living in a technology world, that this is not technology-driven, this is outcome-driven. So here's the first example. CanTry is a daily AI platform or pipeline that looks at incoming pathology reports and identifies high-risk cases in real time as soon as the data becomes available, so it's daily. And we apply this for triple-negative breast cancer, which are very high-risk breast cancer cases. Now, historically, those signals could take time to move through the system. So, you would see a report, the report would land somewhere on an oncologist's desk or inbox, it might be triaged by a triage clerk. And typically in healthcare, we use FIFO, first in, first out. So you might sit somewhere in that list, and it just happens of when you entered in that list. And you can sit in that queue, and you can sit in that queue for a long time. But what this AI approach does is that as soon as the pathology arrives, it flags it. So that allows for earlier oncology review, faster triage, earlier coordination, and quicker entry into the care pathway. So now instead of waiting, we can act earlier. And this really matters because this type of cancer is extremely aggressive. If you don't catch it in the very, very early stages, which you might be in those stages for weeks, maybe months, a couple of months, it is fatal. It is very fatal. But if we catch it early, your survival rates can be between 85 to 90%. So it's extremely important that we flag these cases early and we get them going on treatment as quickly as possible. So this isn't about efficiency. It's fundamentally about changing the outcomes for patients. And I think what's important about how we got here was that we built this model on 2,700 core biopsy reports. Most of them were unstructured, free text reports, which is what we see most of the time. Clinical documentation is really all about that. We didn't start from scratch. We took an established biomedical model, we fine-tuned it on local BC data, and we identified key biomarkers like HER2 status. And it's that combination of a strong base model, local data, adapted to clinical practice that really made this work. And just as important is that we embedded this into the workflows with clinical oversight. If it's not integrated into how we deliver care, then it's useless and it doesn't have any impact. And so it's really important that we worked very closely with our clinicians in order to build this into their workflows. If CanTry was about acting earlier for individual patients, CDPD is really about improving the system itself. And the challenge here is a bit different. A lot of the critical information that we have and that exists is buried in unstructured reports, in particular imaging reports. So that means we don't really have a clear, consistent view of how patients move through the diagnostic pathway. So the question for us here was, how do we make that pathway visible? And this is what CDPD does. It uses AI to extract BI-RAD scores, which are really are predictors of risk, from the imaging reports to standardize that information and then connect it across our data sets, from the screening to diagnosis through to treatment and perhaps all the way back around again, depending on your situation. And that allows us to answer questions we couldn't reliably answer before, like where are the delays happening? Where is there variation? Are there patients who are being lost to follow-up? And how are different patient groups moving through care? And once you see it, you can improve it. And this was really the shift for us from describing what happened to actually improving the care. Now, this is an example of an actual patient journey, end to end. In this case, you can see that it took 59 days from initial presentation for screening mammogram to diagnosis, where a biopsy was performed and the PATH final report indicated presence of cancer. Importantly, what you can see is the clinical context along that journey, what events occurred and how long it was between those events. This patient initially had an imaging result with a BI-RADS score of 4, which means suspicious finding. Something requires further investigation. Usually it involves a biopsy. At that point, the expectation is that the pathway should move pretty quickly. And then we can see what actually happened. There is a referral to a surgeon, an initial visit to the surgeon, another diagnostic mammogram, and then the surgery performed with a classification BI-RADS score 6, which is confirmed cancer. So now we know this is no longer suspicious. This is a confirmed diagnosis. The patient had surgery and then followed up with an oncology consult. This patient continues to be monitored, and the status returns to a BI-RADS 1, indicating no evidence of disease, a success story. So this gives us something we didn't have before. We can see both the clinical progression and the timing between each step. So instead of looking at averages or aggregates, it's about what the system isn't moving as it should. And we can really understand real patient pathways in detail. And in fact, what we've done is taken these pathways and linked them to our breast cancer-specific evidence-based pathways to look at where groups of patients who have similar characteristics are not moving through the system in the way that they should. And that allows us to really identify the bottlenecks, reduce unnecessary delays, and improve how patients move through care. And once you see a pathway like this, you can't ignore it. So taking a step back, what we've shown so far is what's been possible for us. But scaling this across the system, this is just one small example with cancer and breast cancer specifically, that's really where the challenge is. And what we've learned is really AI is not the hard part. It's everything else. On the data side, it's, we have fragmented pipelines across our systems. We have very inconsistent data quality. We have different standards and definitions across every hospital and lab and imaging center. On the system side, integrating into the existing clinical systems is very rigid. We have to fit into real workflows, and then we have to sustain these models over time. And so that's where we put a lot of our efforts. But we've also learned what makes it work. And you've heard a lot today about needing a strong shared data foundation. And it's not just around the data foundation. From my perspective, you really do need consistent identity matching. If we didn't have that, we couldn't move forward at all. You need clear data sharing around organizations. If our organizations didn't want to share data, we couldn't do this. And we actually need defined governance. This is private, confidential information, and we really need to be careful about how we use it and how it's being used. You also need to embed this into workflows. If it's not part of how people actually work, I guarantee you it will not be used. And you have to maintain trust. I was just reading an Ipsos AI monitor that found that 67% of Canadians, so 2/3 of Canadians, feel nervous about AI. You go to China, they don't feel that way. They're excited about AI. We are in a country where there's a lot of fear of AI, and there's a reason for that. But we have to figure out ways in which to build trust. And I do believe that comes with, appropriate access controls, outputs that can actually be reviewed and validated, transparency in how you're making these decisions with your AI, and then your ongoing monitoring. And I think it's really important that it's not a deploy once and be done. Like, this is something that you need to really evolve over time. So to bring it all together, I think earlier today we were asked to come up with one word of what we think about AI and what we should be doing, and I would just say act. But act in a meaningful way and in a manageable way. Find something that has really meaningful difference to the people who you're working with. For us, that was the cancer registry. That's where we started. And really spend a significant amount of time just on the basics. Maybe working in health, we have no choice but to spend time on the basics because we can't afford to get it wrong. But I do think that it pays off because it improves the quality of your data, it improves the trust in your solutions, and people want to buy into it and want to buy into the solution. As well, I think, the foundation is extremely important. If you don't have that foundation, nothing else will scale. And you don't need massive amounts of data in order to be able to get started. And we've heard time and time again today that keep humans in the loop. And I think what I heard the previous speaker even say it is that, if you bring humans in early on in the process, they'll be a heavy part of the beginning. And the AI may not seem like it's really doing much. But over time, as you build confidence and they help you to build confidence in your model and refine your model, you'll rely less and less on those humans, and you'll start to take work off of their plates. And we found that ourselves, that we were actually able to find, with our registrars, actually clear their workflows altogether. They weren't even looking at breast cancer cases because we could clear those completely off their workflow. And once you have all that foundation in place, you can really enable real clinical impact at scale. So while, I'm excited about what we've done, we've just scratched the surface. We're that tiny little 10% down at the bottom there. Because, going forward, there's not going to be just more data. There's going to be more types of data. There's going to be more sources and more complexity. And we're going to be moving into images, genomics, device and monitoring data, and data outside the traditional health system. So things you carry on your watches, it's all going to be part of what's going to drive our health and our health system. So the problems that we're facing right now, they're not going to get any easier. They're actually going to become more complex. And that has a very important implication because what we've built so far is really just the beginning. And our ability to structure data, to link it, and make it usable across the system is going to be even more important as this data expands. And so I think this really reinforces the need to ensure that you invest in your foundation early so that as things expand and grow, you can scale with it. So what does this mean moving forward for us? First, from our perspective, where are we going? We really need to lower the barrier to innovate. Healthcare is, it's very bureaucratic, and it's really difficult to innovate and to move that innovation into implementation. And so we have to be purposeful about creating some test beds and really allowing innovation to grow in our healthcare. We also need to move faster as a system. We're really slow. Like if you look at all the problems in healthcare, people are asking, why aren't you solving them? We are moving way too slow, and we really need to move faster. We need to streamline our governance, make sure that data is accessible to a lot more people to help us solve these problems, and really treat data not as an administrative function, but really as core infrastructure. And third, we need to change our accountability. Right now, people are responsible for their department or their program, but from a patient, it's the journey. And so we need people to not say, well, I'm only responsible for imaging or for surgery. We need them to own the whole patient journey. And that's going to be a huge shift, but I think if we don't do that, we really won't be able to achieve what we want to achieve in healthcare. And I think these three keys will help us move faster, innovate more effectively, and continuously improve how care is delivered. So that's our journey today, and I really appreciate you staying with me and sticking with me and avoiding the alcohol for the last half an hour, and thank you very much. Yeah.
Everyone please put your hands together for our Big Data Summit host, Senior Manager, Channel Performance and Marketing Analytics, Rogers Bank, Neha Baluja.
Thank you so
and our
much.
Big Data and Analytics
it's
Canada
so great to
Summit
hear
Director,
from you at the beginning of the conference and you're closing the conference. So always great insights and really appreciated your presentation today. Please give Alexandra a round of applause.
Thank you.